Hi everyone, good afternoon. So I'm Sean Duffy, I'm the co-founder and CEO of Omada Health. We're a 5.5-year-old company headquartered in San Francisco, and we help people at higher risk of chronic diseases like heart disease and diabetes make lifestyle change in a way that a lot of the clinical science shows can make a difference. So super excited to chat today on how to make outcomes in healthcare matter, more specifically in the behavioral medicine, behavioral therapy space. Just really quickly on me before we begin. So my background's somewhat of a mix between tech and medicine. Studied neuroscience in undergrad, ended up working at Google for a couple years because I grew up a computer geek. Went off to medical school, and then during med school took an internship at IDEO. And actually tomorrow, you'll hear from Dennis Boyle, who's one of IDEO's co-founders. He actually kicked off an internal project at IDEO, which allowed myself and my colleague a bit of time to look at areas in digital health we actually might be able to bring a bit more evidence to the equation, and it led to Omada. So, there's really three pillars to the chat today. First, just the crisis of obesity-related chronic disease. Second, some key principles for driving outcomes in behavioral science. And then third, just to look at how we at Omada improve outcomes through data. So our mission at Omada is to inspire and enable people everywhere to live free of chronic disease. This is literally written on the wall of our office. The words are intentioned. Inspire, we believe, is important because we have to put forward a product or a program that people want to use and they don't feel like they have to use it. It needs to be compelling at the consumer level and seem fun and interesting and sexy. Enable, we really need to put people in a place where they're more likely versus less to succeed. And then enable people everywhere. We think that digital is really the way to scale some of these proven and demonstrated behavioral science interventions. So obesity-related chronic disease, no doubt is one of the crises of the century. For the first time in global human history, preventable chronic disease is killing more people worldwide than infectious disease. In the US, about a year ago, the CDC came out with a pretty startling statistic in that an adult in today's country, an adult in the US today has a 40% chance of at some point in their life finding out that they have type 2 diabetes. So it's a staggering trend. We have about a third of the adult population at risk for diabetes with prediabetes heading toward type 2. So clearly a doom and gloom scenario. The silver lining here is there is actually something that can be done. There's a famous study that kicked off a wave of translational literature in this space called the Diabetes Prevention Study, or Diabetes Prevention Program. It's become one of the most cited studies in medical history. What they did is they took 3,000 people with prediabetes, they randomized them, brought one arm through a very high-touch, in-person lifestyle intervention program that targeted a modest amount of weight loss in the right sort of way, very psychology-forward way. They tried metformin, a drug, and then they had placebo, where they just took the curriculum from the lifestyle intervention, handed it to people, and said, hey, read this, you're at risk for diabetes, go at it alone. And what you see on the chart on the left there is a dramatic split in the conversion from prediabetes into type 2 between people who went through the lifestyle program and people who had nothing. So incredible clinical result. It kicked off a really interesting wave of translationalists and research that's led to a whole lot of momentum to work to make these programs standard of care across the healthcare system in the US. So in 2002, the trial was published. A lot of academics wanted to figure out how to get this research out into the community, out into the clinic. That momentum caused the inclusion of these sorts of programs in the Affordable Care Act. There was a provision called the National Diabetes Prevention Program that gave the CDC the directive to work to propagate these programs as standard of care and provide a baseline level of kind of quality assurance on the delivery of these programs. Omada heard about that effort, wanted to complement the brick and mortar efforts with digital. The American Medical Association got on board. Omada actually has a partnership with AMA and Intermountain to figure out the best ways for physicians and providers to refer into these programs. ADA, US Preventive Services Task Force, issued 2 recommendations, both B-rated, talking about the importance of these programs. And more recently, Secretary Burwell used the anniversary of the Affordable Care Act to announce that Medicare is going to begin reimbursing for these programs. So they're designing a benefit right now. And this is what the gold standard really looked like for these sorts of programs. It was really a very people-based, in-person groups, and there's very good reason for it, in that allowing people to form peer relationships and not feel alone and feel loved and supported and be on a timeline with each other is really critical for these sorts of interventions. Our belief at Omada is that digital can serve as a great complement and can really enhance the broad scalability of these offerings, because all the evidence shows you need multiple touch points to help someone with these programs effectively, and that limits accessibility when it's in person and flexibility. In addition, if you're thinking about creating an engine that ensures that every person in a program makes the program better for the next, you really need to mine the data, be very thoughtful and rigorous about monitoring, and really look at the analytics of how you're doing. So at Omada, our program is on a timeline. It's not too unlike what you'd experience in a face-to-face program, in that we take people at risk. We actually match them into small groups. Omada means group in Greek. So you're matched into groups based on location and demographics. We mail you a digital scale that has a cell phone chip in it. So the moment you step in it, you have an email saying that the scale's connected. So you don't have to pair it with your Wi-Fi network or your phone. And then we kick you off after we set your group up with a health coach on the foundational program, which is 4 months long. And week by week, we unlock lessons. And then after the 4 months, we transition you to a phase called focus, where you have a little bit more ability to set your own goals versus have it standardized. So the idea is to get people in a social setting where all of a sudden you find that on a Sunday you're kicked off, you have a goal that's aligned with everybody in the group, you get to see everybody else's progress toward that goal on a normalized basis, you have a coach who provides a little bit of accountability, and then a structural backbone of curriculum. And that is what you'd experience in a brick and mortar program. This is very unusual for a digital product, because most digital products are not on a timeline. Someone who logs in on week 7 sees the exact same thing who's someone who's just using the product. So it creates this really rich dimensionality for our product team to think about how to sculpt the experience into a narrative. For the last 5.5 years, we've become the world's biggest provider of these programs. We've enrolled over 72,000 participants. We've now amassed, this slide's impossible to keep up to date, now amassed 9 million cumulative weight readings. But we believe this makes it the largest longitudinal data set of lifestyle intervention programs at Omada. And we've from the very, very beginning done this through 4 pillars. We talk about this at the company. Anytime we think about introducing new features, we talk about our pillars, which is starting with science, making sure there's already existing evidence to support something that should be done. Deepen with design, make sure to make the product experience as delightful and interesting as possible so that it pulls people in. Empower with people. We think people are incredibly important in these interventions, and that will continue. And then insisting on outcomes, which is really the tenor of the talk. So from an outcome standpoint, at Omada, we've believed in that from day one. We publish papers. We actually price on outcomes. So we make all of our profit when we get people to weight loss milestones as measured by 3 readings from the cellular scale. And we've done that from the beginning, and we really think that differentiates in the market and really aligns our incentives with our partners. So I'll show a quick behind-the-scenes video on how we think about insisting on outcomes at Omada. What I love about Omada is it's incredibly nerve-wracking from a business standpoint to sign a contract where there's not any revenue from it unless we get people into our program, we get them through our program, and we get them to lose meaningful weight. But that's awesome, because what that does is it puts our feet to the fire.
The outcomes that we're really trying to achieve happen in a patient's body. And the trap that other companies have fallen into in this space in the past is assuming that delivery of the program is the same as a meaningful clinical outcome in a patient's body. And that's just not true.
I think it's important to publish and be transparent with outcomes, for a whole host of reasons. One, if you're not delivering a clinical outcome, why are you in business?
Each new Prevent participant really benefits from the learnings that we get from the thousands upon thousands of previous participants that have completed Prevent. We're at a point now where we can tell fairly early on how a participant is likely to do much later in the program. Using this knowledge, health coaches can intervene to get a participant back on track before they actually get off track. And this has really changed everything.
Anytime an HR customer of ours asks me how they should evaluate programs, I tell them to go out and look in the clinical literature for peer-reviewed publications on whether or not those programs produce outcomes. We're moving to a point in time where real medicine is being paid for by employers, and employers need to learn about it.
I would challenge people to say, why am I paying a per employee per month or a fixed fee rather than focusing on paying for outcomes? When a vendor or a partner comes to me and says, I'm going to deliver this, we should pay them on what they say they're going to deliver. And that's something that's totally missing in healthcare.
people can do a lot of things, but it may have no impact on their body and their health over the long term because it doesn't actually change their behavior in a meaningful way.
We are trying to change the game. We're trying to say that this is something that's hard. It's been hard for you. It's been a problem for you. It hasn't been solved. Healthcare costs are still rising. So you need partners that will align their financial incentives to you. And that is something that we're willing to do.
So we felt extremely strongly on that from the very, very beginning. Published multiple papers. We've published 2-year data of a reduction in weight loss benchmarked against the CDC standards for these sorts of programs. We've worked with the VA on a study where they sent participants to an in-person weight loss program called MOVE, that's the top line, an in-person diabetes prevention program, it's the green, and then Omada, the orange, to really help demonstrate that digital can meet equivalency with these very, very intensive in-person high-touch programs. And we'll continue. And there are some key principles that over the last 5.5 years we've aligned on internally on why I think our program works, but also have broad applicability to really any product or any program that's trying to pull people along and move behavior. One I call data for data's sake, which is just telling people that they're at risk, showing them a lab report, setting them up with a scale and a chart. Usually that's not enough, and the control arm of most studies really represents data for data's sake. In the DPP original trial, they handed people the curriculum and said, do it yourself, after telling them they're at risk. And you very frequently see this, where you're just showing someone an abnormal lab value and praying that they go out and do what it takes to make change is very, very unlikely. There was a study that maybe some of you saw with Scripps Wired for Health that looked at a monitoring program from Digital Health and saw no clinical benefit. And if you read through the pub, this was a fabulous study that it was done. It was really just showing people data and really hoping that they take action without context around it. So, we really, really think that data is the ticket of entry. You need to use it and contextualize it. The second is design matters. And when we say design, I always talk about big D design, not the visuals, really the user experience design. And one tech example of why this matters is Instagram. When Instagram first launched as a product, there were plenty of other photo sharing, photo apps on the App Store, and it caught fire for a number of reasons, and some were really, really behind the scenes from a design standpoint. One that's really interesting is as you select your Instagram filter, the image is being uploaded to the server in the background so that when you go to post to your network, it's instantaneous. You don't have to wait and have a lag after you've altered the image before it gets sent up. So it reduces the latency to get the experience of sending it to your account. So they did that. Little details like that matter. In healthcare, this is Pfizer's inhalable insulin Exubera. And this was actually a flop in the market. It launched. It made it through the FDA, and consumers didn't like it. If you look at the device, I think people in the audience can imagine why and how cumbersome and awkward that might be to just pull out of your bag, amongst all of your friends, or even go into the bathroom and use that device. People would wonder what you're doing. It's an example of usability design. That may have crippled the entire inhalable insulin category because all the other pharmaceutical companies reacted to that failure and uninvested in it. The next is I call it the single instrument fallacy, in that it's usually never one thing that makes a product work or an experience like what we try to build work. It's a combination of a lot. You see this in the activity tracker space. You can't just put a Fitbit or an accelerometer in someone's hands and just hope that that's enough to really move the needle on any clinical endpoint you want to target. You can't just hand the curriculum over. Anyone in this room at risk for diabetes could go to the CDC's website and download their version of the curriculum for these programs. It just won't happen, on itself. This is a randomized controlled trial of MyFitnessPal, which actually is one of the, I think is actually the best food tracking app on the App Store. They wanted to see if there was a clinical impact in prescribing it. There wasn't. It's just one tool. The health coaching DM world in yesterday's era consisted of, in large part of, folks on phone lines trying to reach out to people, hoping that little connection that you could build over the other end of a telephone line was enough to create the emotional resonance to move someone toward more health. It's tough if that's the only thing. It's really challenging to just put people onto a message board and really hope that that alone achieves the outcome you want. You really have to tie them all together. And if you're Beethoven trying to write the Fifth and you want something that's emotionally moving, you can't just do it with the bassoonist. You can't even do it with just all the instruments. You actually have to put them on a score and have them appear and fade out and fade in over time and create a story with it. I think there are lots of areas where that's true. Another, in the last kind of key dimension that I firmly believe is really important for behavioral science and also just moving behavior generally, I think this is one of the most powerful tools in anyone's toolkit, is peer references on a timeline or a time bound with normalized measures. Meaning, how are you doing relative to other people like you over a period of time on a metric that's actually something that you can compare apples to apples against each other? This is an example in the utility space. There's a company called O-Power, and they send you a report of your electricity usage, and they benchmark it against your neighbors. So you're already pre-selected to a cohort. They see how you see how you're doing against your neighbors. It really moves behavior. In Omada's program, it's seeing how other people in the group are doing on the same timeline and feeling that accountability, that support, that inspiration, that peer pressure to work to stay in it and really achieve. This is a very, very effective setup to create. So those are some key principles, and then the next step beyond that is to use the data to work to improve outcomes. So at Omada we now have 9 million weight readings. If you toss them on a scatter plot, it looks like the yellow, orange, and red chart. The darkness of the chart area indicates the higher density of readings, and that's actually out to 3 years, with the dotted line being 0% weight loss, and then the blue is the median with kind of an air cone around it. So these data allow you to really explore why it worked so well for someone near the bottom, why it didn't work as well for someone who maybe gained a little bit of weight in the program, why the vast majority of participants are where they are, and you try to cluster and learn with the goal of making sure that everyone is contributing to the program being better and better each and every day. Because unlike a drug or a device, these aren't the sort of programs where you put them in an oven, set a timer, hear a ding, and call it a day. These are constantly evolving. You can also look at the data on a micro level, where you see all the little interactions that someone could have with your program, be it did they open a lesson? Did they respond to a group post? Did they like somebody else's post? Did they read their health coach message? Did they weigh themselves on their scale? Did they go to their inbox? And you can look at correlations between the activities at the micro level in the program and the person's outcomes from a weight loss standpoint. So, really, really powerful tools, and it allows you to create what we call real-time randomized controlled experiments. You can almost think of these as miniature RCTs, randomized controlled trials, inside of our product, where we'll slightly change one feature, send 1,000 people through that arm, 1,000 people through the control arm, and see if that had any impact. So we have a data science team that, for every product launch, makes sure to rig up an experimental architecture to measure it. And little things matter. I mean, we launched one where we slightly reduced the latency with which your health coach would give you feedback if you entered a meal, and that lifted engagement of using tracking at that point in the program where we were supposed to, and also lifted 16-week weight loss outcomes by 0.39%. So the goal is to constantly learn, constantly figure out what really works, and work to quantify what's been really shown in the behavioral medicine research to be effective in various kind of pockets. There's a discipline called behavioral medicine. They really think deeply about all the discrete elements that go into moving behavior. How you set goals, how you create social pressures, what works, how you communicate, do incentives work, just all the nuance to working to achieve an outcome. These really interactions have been incredibly difficult to quantify until you're able to deliver these digitally, and you can measure each and every one of them. And once we start at Omada enrolling millions and millions of people a year, our hope is we help demystify a lot of this and contribute to the literature, publish different nuances that might have broader applicability across the healthcare space generally, and really use our engine here to innovate. So we think that the world is really in this space is really at a neat tipping point. The CMS news has already started to catalyze broader interest in the space. It's really, in a really beautiful way, it's allowing companies like Omada to get closer and closer to the provider as more market access is built, as more coverage is put into place. That allows us to work in a different way with health systems, which is really fun. All of my medical school colleagues, they're now practicing, doctors, and they keep asking, when can I prescribe your program, when can I refer patients? And I keep telling them someday soon. So that point, we believe is well on its way, and this year really marks the transition point for our company to even, more deep level engage. Want to close the chat with really showing some voices from participants in the program. I've picked people from some Medicare Advantage work that we've done, which I think is a really neat, interesting population for a number of reasons. Obviously, the CMS, reimbursement news. The second is I think it's increasingly becoming, known that grandmothers are getting iPads. Technology is spreading to the underserved, to the above 65 at pretty fantastic rates. And if you work really hard to make the user experience incredibly simple, so that there's no setup, there's no headaches to get going, it can be really effective for folks above 65. So with that, we'll play the video.
No, I'm not a tech-savvy person. I'm not.
No.
I like to think I am. Okay.
I didn't think I needed to change that much. That was the problem.
It was kind of mind-boggling to think, hey, I can step on this scale here and it's transmitting my weight to them. After a few times, you do it without even thinking about it.
Even though it's online, you feel very much a part of a community.
It got to be a competition with the other 60 members of the group. I wanted to be one of the first ones to lose the weight. I took my scale on vacation. It was really good because if you don't get that feedback, it's easy to stray.
If I don't get in the steps that I really need for that day, when I go places, I park far away. My great-granddaughter, she kept saying, Grandmama, why are you parking so far from the door? I said, because I need to get in the rest of my steps for the day. It's just second nature for me now.
I had a very poor self-image, and it was one that was probably hidden by a lot of other things, such as trying to be the comedian or making jokes about how big I was, and it kept me from doing a lot of things.
It was kind of a wake-up call for me that I was in this category of pre-diabetic because I had never really thought of myself as that before.
I was convinced that I worked out strenuously every day. When I actually measured it, it was a whole lot. It was several orders of magnitude less than I thought. Got to a point that if you didn't work out, you missed it. And that's like, oh wow, it's not bad.
I tracked my food and activity religiously. It was having the effect of making me avoid certain things that I would have just automatically reached for before.
Favorite part of the program was watching the weight chart go down. Thank you.
The doctor even said that that's enough, that's good enough. You just try to maintain that and you'll be in good shape. And I'm off the blood pressure pills. Yeah, I did it, and I could have done it without them.
When I did reach the first goal that they set, and I think that morning when I weighed, I hollered out and said, hey, I have made it.
I realized the fact that there's no way you can look the same as you did when you was 20. But then too, when you get 75, if you don't look like you're 90, you've accomplished something right during their lifetime.
Wonderful. Well, thank you all for your time. If you have any questions at all, just email me. Email is just Sean, SEAN, @omadahealth.com. Wonderful.